Hello, welcome to the Caregiver Empowerment Programme. Today's webinar is on mood difficulties in children and adolescents, Part 1. This is a new healthcare services community support initiative supporting children and adolescents with mental health difficulties. My name is Dr. Jill Pollard and I work as a senior clinical psychologist with New Healthcare Services. About this webinar has been designed to provide helpful information about mood difficulties and how they present in childhood and adolescence. In part 1 of this webinar, we will talk about the main features of mood difficulties and how to know when they present as a problem, for which supports need to be explored. We will also talk about the process of diagnosing a mood disorder and the assessments used. In part 2, we will summarise the main evidence-based interventions and supports for mood disorders in children and adolescents, with guidance to additional supports, resources, helpful books and groups. These webinars are suitable for caregivers and family members who are involved in providing care to a child or adolescent with mood difficulties, or for individuals who would like to know more about mood difficulties in childhood and adolescence. So let's look at what we will be covering in this webinar. Firstly, we'll be looking at what is a mood disorder, then causes of mood disorders, diagnosing mood disorders, and finally a summary. Topic 1. What is a mood disorder? A mood disorder is a mental health condition that severely impacts an individual's emotional state. It's common for individuals to have mood problems from time to time, and there are normal fluctuations in moods. However, a mood disorder refers to more intense feelings of sadness than usual. They can also be associated with fluctuations in our mood. Mood disorders tend to affect sleep, appetite, energy levels, and thinking abilities. When mood problems are more extreme and occur over longer periods of time, it may be a sign of a potential mood disorder. Unlike normal bad moods, mood problems involve intense, persistent, and difficult to manage thoughts and feelings. For a child or young person, this might include how they feel and how they engage with day-to-day activities, such as school and hobbies, and their relationships with others, including friendships. It's a broad term that includes different types of disorders which affect mood. Types of mood disorders include major depressive disorder. This involves depressed mood, chronic feelings of sadness, guilt, or worthlessness. And then there is persistent depressive disorder. This is where there's consistent depressed or irritable mood lasting for 1 year or longer. And then there's disruptive mood dysregulation disorder, which involves severe recurrent temper outbursts. So that's more associated with anger. And then we have premenstrual dysphoric disorder. So that's related to hormonal changes in relation to menstruation. And then finally, we have bipolar disorder, which refers to difficulties with extremes of mood. So somebody experiencing highs and lows. Mood disorders affect how a person thinks, feels, behaves, interacts with others, how they see the world, and how they feel physically. So let's look at the signs of a mood disorder. So some of the signs of a mood disorder might include negative self-talk. That's where somebody talks very negatively about themselves or put themselves down a lot. It can involve low self-confidence, negative responses to others, social withdrawal, so being uninterested in social events or outings, preferring to spend more time alone, being easily irritated or angered, increased sensitivity to rejection, changes in appetite, so where a child or young person is either eating a lot more or a lot less than they would normally. Changes in sleep patterns. So again, where a child or young person is maybe sleeping for longer periods or are having a lot of difficulty sleeping and have disturbed sleep. It can also involve vocal outbursts or crying, difficulties concentrating, fatigue or low energy, physical complaints, so complaining of physical pain, complaining of feeling unwell, stomach aches, feelings of worthlessness and guilt, thoughts or vocalizations of death or suicide. So perhaps expressing that they would rather be dead or that they're having thoughts of killing themselves. Self-harming behavior. So anything that would involve hurting themselves. Low motivation. Not wanting to do the things that they would normally do. Feeling hopeless. Not looking forward to things and not enjoying the things that they previously enjoyed. Let's look at the signs of a mood disorder by age and stage of development. So in very young children from 3 to 5 years of age, they'll often have difficulty verbalizing or expressing their feelings. So in that way, we'll look for changes in their behavior. So we might see a marked decreased interest in play. We might see more self-destructive themes in play. Thoughts of worthlessness or appearing sad or down. In children who are 6 to 8 years of age, they will often have difficulties verbalizing their emotions as well. So we might see increased somatic complaints. So in that way, increased physical complaints. So complaining of pains, aches, tummy aches, complaining of feeling unwell. We might see more crying or shouting outbursts than normal. Unexplained irritability. Not enjoying things and appearing sad or flat. In children who are 9 to 12 years of age, we might see low self-esteem, guilt, hopelessness, increased boredom, feelings of wanting to run away, and perhaps a fear of death. In children who are 13 to 18 years of age, we'll see more increased irritability, impulsivity and behaviour changes, decreased school performance, increased disturbances in sleep and appetite, and suicidality. Now let's look at normal moods versus mood disorder. So feeling low or high are normal experiences that all children and young people have from time to time. A child might feel really low for a time after a loss or setback. So for example, a friend moving away or a pet passing away. A child or young person might feel really high after an accomplishment. So maybe winning a race in school or being invited to their friend's house. These feelings come and go, and it's not long before they return to their normal baseline. Children typically learn to regulate these feelings by seeking comfort from caregivers or parents, doing things that either improve their mood or calm themselves. So, when might it become a problem? A mood disorder occurs when your mood is more intense than normal, when difficulties last longer, so for at least 2 weeks, where it impacts the child or young person's ability to engage with daily activities. Low mood, on the other hand, tends to be linked to specific events. So something that's happened in the child's life. So maybe a friend moving away, a grandparent passing away. However, these mood difficulties tend to be resolved when time passes and circumstances improve. And we often see that low mood in these cases are interspersed with periods of positive emotions. And it's not accompanied by pervasive feelings of worthlessness or self-loathing. So we see that the low mood is associated with a specific event or time period in a child's life, and it's interspersed with periods of positive emotions. A mood disorder, on the other hand, tends to impact all aspects of a child's life. It lasts weeks or months at a time, at high intensity, or consistently at lower intensity. It severely impacts an individual's ability to function in terms of socializing, education, and self-care. It also tends to very much negatively impact how the child or young person feels about themselves, and it's associated with pervasive feelings of worthlessness and self-loathing. There are two major types of mood disorders: depressive disorders and bipolar disorders. Under depressive disorders, we have major depressive disorder, which is a depressed mood lasting at least 2 weeks. This can occur in cycles. We also have persistent depressive disorder, or dysthymia. This is where you have chronic, lower intense depressed mood that lasts for at least a year. Then we have premenstrual dysphoric disorder, which is depressive symptoms or irritability and tension before menstruation. Then in terms of bipolar disorders, there are 2 types. Bipolar 1 disorder, which is alternating episodes of mania and depression, and bipolar 2 disorders, which are alternating episodes of hypomania and depression. Let's look at mood disorder symptoms. So for the depressive disorders, in terms of perception, we would see that a child or young person would focus more on the negative things in life. They may misperceive situations, they may see the negative in things that happen, and they might tend to downplay or ignore positive things that happen. It impacts thinking. So a child or young person would have a negative view of themselves, others, in the world. They would have difficulties concentrating and focusing. We would see excessive guilt. They may feel guilty that they're not living up to their own or other people's standards. They may feel guilty about disappointing people. They may believe that they deserve punishment or that they deserve failure. There also might be extreme hopelessness, where they're not looking forward to anything in the future or feel that the situation won't change. There can be the potential for suicidal ideation, where somebody is having thoughts of suicide. And suicidal intent would be where somebody actually has an intent or plan to commit suicide. So suicidal ideation would involve thoughts of suicide, and the intent is an actual plan to commit suicide. There may be maximising the significance of negative events and minimising the significance of positive events. So there may be a tendency to focus in on the negative while ignoring and minimising positive events. In terms of mood, we see feelings of intense sadness, loneliness, or despair. There might be an inability to feel pleasure or to enjoy things. There can be a potential irritation, anger, or anxiety in relation to loss, similar to what's seen in grief. So we might see that somebody is more angry or irritable than usual. In terms of depressive disorders, we would also see a change in behaviour. So there may be a reduction in activity levels, where a child or young person appears to be more slow or sluggish than usual. There might be increased purposeless activities, so pacing around, restlessness, moving items around for no reason. We would see reduced engagement in activities that bring pleasure or sense of purpose or achievement. So, for example, a child who really enjoys playing with Lego, we might see that they're not playing with their Lego or building things anymore. For a child or a young person who loves to draw or to paint, they're not taking out their paints or their pencils to draw. Maybe a child that loves football, we're not seeing them practice their football in the garden like they used to. Depressive disorders can also lead to physical sensations. So there's often a loss of energy, and it's associated with a fatigue. We see that there's a sleep disturbance. So a child is either oversleeping or they're waking frequently or can't get off to sleep. Sometimes we'll see difficulties with children waking in the morning. There can be a loss of appetite, which might be associated with weight loss. There also can be a tendency to overeat. It might be associated with abnormal pains or headaches. So a child or young person might be complaining of feeling unwell, having headaches, stomach aches. For older adolescents, there may be a loss of interest in sex or meeting peers. It can also lead to relationship difficulties. So children or young people might withdraw from peer relationships. There may be a deterioration in family relationships and poor school performance. Mood disorder symptoms in bipolar disorders. So, bipolar disorders tend to be more prevalent in adults and older adolescents. It's not something that is commonly diagnosed in younger children. However, we are going to go through the symptoms because they can be relevant for some adolescents. So with bipolar disorders, we might see a change in perception. So it's characterized by inflated self-esteem or grandiosity. So it's whereby somebody might feel that they have superior abilities to others, or that they have talents that they need to express. There might be abnormal increase in sensory perception. So colors might appear especially vivid. There might be a preoccupation with textures or hypersensitivity to sounds. In terms of thinking, we'll see a loss of normal social inhibitions. So we might see somebody where they're very heightened, very high, and they are saying things that they wouldn't ordinarily say. There might be poor concentration or focus, so they're moving from one thing to another, easily distracted, and there might be an expression of overly optimistic ideas. In terms of mood, we'll see elevated mood ranging from carefree joviality to almost uncontrollable excitement. So it's where we see somebody where they're very heightened. They might become aggressive, amorous, or facetious in inappropriate situations. We might see increased irritability or suspicion. We will also see a change in behaviour. So you will see increased activity, pressure of speech, so speaking really quickly, a decreased need for sleep. So you might see that the person sleeps less than normal. The person may engage in impractical or extravagant ideas. They might spend money recklessly. They might not perceive danger in the same way as previously. They might engage in risky behaviours. There may be increased energy, and they might engage in risky sexual behaviours. Symptoms of mood disorders can present differently in children versus adolescents. So in children, we might see more sadness, irritability, clinginess, worry, aches and pains, like stomach aches, refusing to go to school, or losing weight, being underweight. In adolescence, we might see more irritability, more feelings of worthlessness, poor academic performance, poor attendance at school, feeling misunderstood and extremely sensitive. We might see adolescents starting to use recreational drugs or alcohol. We might see an increase or a decrease in sleeping, an avoidance of social interaction or withdrawal, and perhaps behaviours of self-harm. Let's look at Tom's story. Tom, age 14, seems to have had a total change of personality. At least that is how his mother sees it. He has become moody, irritable, and verbally abusive to the rest of the family, and refuses to discuss what is wrong. He spends most of the time in his bedroom, taking his meals there and often locking himself in for hours on end. He no longer goes out and seems to have no interest in anything other than eating, which occupies a good deal of his time. He has gained a lot of weight, which his mother attributes to his lack of activity and his overeating. She worries that he might be on drugs, but cannot think how he would get them as he rarely leaves the house and has no friends. He can be heard up at night when the rest of the family have gone to bed, but is unrousable in the morning and would sleep until the late afternoon if allowed to. Sometimes his mother allows this, as once he is awake, the atmosphere in the house is almost unbearable. Occasionally, he has good days when it's possible to talk to him, but he is mostly reluctant to talk and tells his mother to get off my case. She knows about adolescent mood swings, having reared two other teenagers, and she wonders if this is an extreme case of normal adolescent behaviour. So this extract is taken from Coping with Depression in Young People, A Guide for Parents by Fitzpatrick C. and Shari J. 2004. So let's look at a recap. of what is a mood disorder. A mood disorder is a condition that severely impacts mood and ability to function. There are two major categories of mood disorders: depressive disorders and bipolar disorders. We know that bipolar disorders are more commonly diagnosed in adults, but it can also be diagnosed in older adolescents. Feeling really low or high are normal experiences that everyone has. A mood disorder only occurs when the feelings are excessively intense, last a long time, and severely impact daily functioning. Depressive disorders include feeling low, loss of interest, withdrawal, hopelessness, and a negative self view. Bipolar disorders involve alternative episodes of high, so in terms of mania, and low mood depression. Now let's look at topic 2, causes of mood disorders. There are a number of factors that can influence the development of a mood disorder. These include genetic predisposition, personality traits, environmental factors, home, family environment, substance abuse, neurological differences, and differences in how our brains work. There are a variety of different theories that attempt to explain how these factors can lead to a mood disorder. These include biological theories, stress theories, psychoanalytical theories, cognitive behavioural theories, and social theories. So let's look at some of these causes in more detail. So genetics. People with a family history of mood disorders are at greater risk of developing one themselves. Studies comparing identical twins have found that when one twin develops a mood disorder, the likelihood of the other developing it can be between 35 to 70%. So we can see that there's a high genetic association with mood disorders. Personality traits. People high in certain personality traits are at increased risks of developing mood disorders. These include people who tend to have maybe more negative perceptions, individuals who tend to have more low self-esteem, people who are more prone to pessimism or self-critical thoughts, people who are maybe tend to be more dependent on others or who have a lower coping threshold. There are certain environmental factors that are associated with mood disorders. Traumatic events such as the loss of a parent or close family member, or childhood neglect or abuse can be associated with mood disorders. High levels of persistent stress, financial difficulties, or continuous conflict in relationships can be associated with mood disorders. In terms of a home family environment, overly critical or neglectful parenting can be associated with mood disorders. Having a family member with a mental health difficulty can also increase the risk. Familial conflict can increase the risk of a mood disorder. Socioeconomic class or difficulties, poor communication, and the absence of a support network can also increase the risks. Certain neurological differences can also increase the risk of mood disorders. So certain neurological conditions like epilepsy, ADHD, and autism can impact an individual's ability to function, which can increase the likelihood of mood disorders. Medications used to treat neurological conditions can have side effects impacting mood. And neurological conditions that impact brain function or disrupt normal chemical imbalance can increase the risk of mood disorders. Tom's story continued. Tom's mother discusses her concerns with his father. He is inclined to view Tom's behaviour as due to laziness and feels he needs the modern day equivalent of a kick in the pants. He has tried this approach in the past, but it has not worked. He tries again, giving Tom a good talking to, demanding that he be more polite to the family and that he gets up for school each day. He is not there to enforce this as he leaves for work at 7 a.m, and Tom's mother cannot enforce it either. Tom's behaviour gets worse. Now he has stopped going to school, saying he is too tired. Tom's parents discuss the situation further. They cannot understand why Tom, who was a very active boy until 2 years ago, should have become so tired and lazy. They decide to take him to the doctor for a checkup. Tom's mother picks a time when Tom is calm, and so is she, and suggests that he should have a checkup with the family doctor. He is not at all keen to go, but agrees reluctantly when his mother says they need to find out why he is so tired. Let's look at a recap of the causes of mood disorders. There are a number of factors which can contribute to the development of a mood disorder. These include genetic predisposition, certain personality traits, environmental factors, home, family, environment factors, substance abuse, and neurological differences. Now let's look at topic 3, diagnosing mood disorders. Diagnosing mood disorders. As we learned earlier, mood disorders cover a range of different disorders. These generally come under two groups: depressive disorders and bipolar disorders. Many mood disorders are classified as either episodic or non-episodic. This means the symptoms either come and go, so they're episodic in waves or episodes, or they are present consistently, so i.e. non-episodic. Conditions like major depressive disorder or bipolar disorder are episodic. This means there is a fluctuation in mood states. For example, in major depressive disorder, a person can fluctuate between extremely low mood and normal mood with support. In bipolar, a person goes from extreme high to low moods. For non-episodic conditions, the person experiences consistent but less intensive symptoms. These can include dysthymia, which is milder but consistent form of depression, and cyclothymia, milder, consistent form of bipolar mood disorder. Diagnosing mood disorders. If you're concerned about your child or young person's mood, the first step is to bring them to their GP. Your GP may refer your child to a mental health professional or service where an assessment can be completed. Diagnostic assessments for depression are generally completed by a psychologist or psychiatrist. There are a number of steps to the assessment which are carried out in order of priority. So, first of all, a clinician will assess the risk of self-harm, and they'll assess for risk of suicide. They'll also assess for the presence of abuse. They'll also look at the extent of symptoms and try to understand the context of the mood difficulties. Assessments are carried out using structured interviews. A mental health professional will interview your child and you as a parent. Depending on the context, they may ask to speak with other people in your child's life, such as teachers or other family members as appropriate. A number of psychometric assessments may be administered. These often look like questionnaires that you or your child might complete with the support of a mental health professional. Or alternatively, you might be asked a series of questions. So first of all, looking at assessing self-harm. Self-harm and suicidal ideation are a major risk for young people experiencing mood difficulties, particularly low mood. The rates of suicide are rare in childhood, so less than 2 per 100,000. But in adolescence, there would be 7.9 to 16.1 per 100,000, and in female adolescents, 2.1 to 3.5 per 100,000. These reported rates may be an underrepresentation of the actual rates, as reporting practices differ in different countries, and there is a perceived need to protect families from stigmatisation. Self-harm is far more common than suicide. 10% of adolescents self-harm. Girls are more likely to self-harm and attempt suicide than boys. 1 in 8 adolescents present to hospital with self-harm injuries, and most cases of self-harm in adolescence ceases by adulthood. Girls who self-harm are more likely to have a history of anxiety or depression. Young people with mood difficulties are more likely to engage in self-harming and suicidal ideation if a young person presents with either of these. A risk assessment will be carried out. These This involves assessing likelihood the person wants to commit suicide. So how much thoughts they're having about committing suicide, the presence of a plan for suicide, access to means to carry out a plan, the intensity of thoughts associated with self-harm or suicide, and circumstances that led to self-harm. The assessment will also look at protective factors in place, so things that actually keep the child or young person safe. The above information is gathered through interviews and assessments. Clinicians will then use this information to make a judgment about the likelihood of further self-harm or suicide attempts. A plan will then be developed with the young person, parents, and other significant individuals to help the young person keep themselves safe when they feel at risk of self-harm. Next, let's look at diagnosing mood disorders. We're going to look at major depressive disorder first. So firstly, at least 5 of the following symptoms must have been present during the same 2-week period, and it must represent a change from previous functioning, and at least one symptom must be either depressed mood or loss of pleasure. So the symptoms would include low depressed mood, loss of interest or pleasure in all or almost all activities, significant weight gain or loss or change in appetite, insomnia or hypersomnia nearly every day. So insomnia would be where a person can't sleep, and hypersomnia is where a person is oversleeping. Psychomotor agitation, so actions without purpose or retardation, slowing down nearly every day. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive inappropriate guilt nearly every day. Diminished ability to think or concentrate nearly every day. Recurrent thoughts of death, suicidal ideation, suicide attempt, or plan for committing suicide. The symptoms cause significant distress or impairment in everyday functioning. The episode is not attributable to the physiological effects of a substance or another medication, and the symptoms are not better explained by schizophrenia or psychotic disorder. And there has never been a manic or hypomanic episode. To summarise, there are 9 symptoms listed, and an individual would have to have at least 5 of the symptoms during the same 2-week period in order to meet criteria for a diagnosis, and the symptoms must cause significant distress or impairment, and it's not attributable to a substance or another medical condition. And it's not better explained by schizophrenia or psychotic disorder, and there's never been a manic or hypomanic episode. So now let's look at diagnosing bipolar disorder. There are 3 forms of bipolar disorder: bipolar 1 disorder, bipolar 2 disorder, cyclothymia. Bipolar 1 disorder, at least one manic episode. Manic and major depressive episodes are not better explained by another disorder. And bipolar 2 disorder, at least one episode of both hypomania and major depression. There has never been a manic episode, and episodes are not better explained by another disorder. And with cyclothymia, a milder form of bipolar 1 and 2, where episodes of hypomania and mild to moderate depression are experienced. So diagnosing a manic episode. So firstly, a distinct period of abnormally and persistently elevated, expansive or irritable mood, increased goal-directed activity or energy, lasting at least a week and present most of the day, almost every day. B, during the period of mood disturbance and increased energy, 3 or more of the following symptoms are present and represent a noticeable change from usual behaviour. So those symptoms are inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual or faster speech, flight of ideas or racing thoughts, distractibility, increased goal-directed activity or psychomotor agitation, excessive involvement in activities that have a high potential for painful consequences. And C, causes functional impairment or leads to hospitalization to prevent harm to self or others. Or there are psychotic symptoms. And D, not due to the physiological effects of a substance or a medical condition. A hypomania episode. So A distinct period of abnormally and persistently elevated, expansive or irritable mood, increased goal-directed activity or energy, lasting at least 4 consecutive days and present for most of the day, almost every day. During the period of mood disturbance and increased energy, 3 or more of the following symptoms are present and represent a noticeable change from usual behaviour. 1. Inflated self-esteem, grandiosity. 2. Decreased need for sleep. 3. More talkative than usual, faster speech. Flight of ideas or racing thoughts. Distractibility. Increased goal-directed activity or psychomotor agitation. Excessive involvement in activities that have a high potential for painful consequences. C. The episode is associated with unequivocal change in functioning that is uncharacteristic of the individual when not symptomatic. D. The mood disturbances and change in functioning is observed by others. And E. Does not cause marked functional impairment, psychotic features, or hospitalization. So now let's look at diagnostic assessments. So for depression, a number of different assessment measures may be used depending on the person's presentation. These may include the Childhood Depression Inventory, the Beck Youth Inventory, the Hopelessness Scale for Children, and the Beck's Suicidal Ideation Scale. These questionnaires can be done with the young person or parents and help screen for depression symptoms. In terms of bipolar disorder, a multidisciplinary team, including psychiatry and psychology, are involved in diagnosing bipolar mood disorder. Structured clinical interviews are carried out, and these either use the Schedule for Affective Disorders and Schizophrenia for school-age children or the Diagnostic Interview Schedule for children. Tom's story continued. Tom's family doctor talks to Tom's mother first and then sees Tom on his own. She gives him a physical checkup and while doing this asks him a few questions about how things are going with his friends, school and football, which Tom used to play but no longer does. Tom talks a little to the doctor, saying he doesn't have any friends, does not want to play football and has not been going to school. In response to the doctor's low-key questions, Tom says that he is feeling awful and does not know why. He tells the doctor he's been thinking of suicide a lot and cannot get it out of his mind. The doctor tells Tom that his physical checkup has not shown any medical problem that could explain how he is feeling. She suggests to Tom that it would be a good idea to see someone who might be able to help him with the difficult feelings he's been having. She does not label Tom's experience as depression, as she is not sure herself that is what it is, and she also knows that boys of Tom's age are often very reluctant to accept that label. Tom reluctantly agrees to the doctor's suggestion. So let's look at a recap of diagnosing mood disorders. So mood disorders covers a broad range of different disorders. These generally come under the headings of either depressive disorders or bipolar disorders. Every mood disorder has its own list of symptoms and specific ways of assessing for the conditions. Self-harm and suicidal ideation are a major risk factor in young people with a mood disorder. As such, special care is taken to screen for any self-harm or suicidal behaviour, and plans are put in place if necessary to keep the person safe. Mood disorders are diagnosed through comprehensive interviews and assessments done with the young person, parents, and other relevant individuals as necessary. Now, let's look at a summary of what we've discussed so far. Today we went through some helpful information about mood difficulties in children and adolescents. Compared to before we started a couple of hours ago, you should now have a greater understanding of what a mood disorder is and when mood difficulties require support. The cognitive, affective, physiological, behavioural and relational aspects of different mood disorders. Coming next, we will discuss in part 2 mood difficulties in children and adolescents, interventions and strategies for supporting the child, interventions for mood disorders, strategies for supporting mood and where to get support. Join me in part 2 next. These are the references for today's presentation. Thank you for your time and attention during today's webinar. We hope you found it helpful. Should you wish to add structure to your caregiver routine, please refer to the sample tools and third-party resources associated with this webinar, which have been conveniently uploaded to your learner area of the learning management system. Please keep in mind that these are only samples, and with your newly acquired knowledge, you may choose to use these in whole or in part or research alternative resources and tools yourself. If you have questions in relation to any of the topics or areas raised during today's webinar, please feel free to contact our team by emailing clinicaldepartment@newahealthcare.ie. Thank you very much for your time, and I hope that you join me in part 2 of this webinar on mood disorders, where we'll be focusing on strategies and interventions. Thank you.